try and slow things down without being abrupt. Let's try and break this down a little bit. You're going through a lot. You're telling me a lot right now. Can I start by asking you a few specific questions about the pain that you mentioned or something like that? But just try and slow it down. And slowing your voice down can slow the whole tempo of this type of case. What I often see is when you get patients and consultations where the patient is talking so fast, the doctor starts to talk so fast as well. And the whole thing is such a blur that you can hardly hear what's going on. Slow things down. Mrs. X, look, firstly, let me just say, it sounds like you've got a lot to tell me and I'm here to listen. Let's maybe try and break this down a bit so we can get more done for you. Do you mind if I ask you a few specific questions about X and retake control without being abrupt? Flipping back is something that you're going to find yourself doing a lot in this type of case. Why? Because the talkative consultation, people go from one thing to another to another. So they'll be talking about pain in the knee and they'll jump onto, oh, but also that caused pain in the back. And then last year I realized that because I wasn't exercising because of my back pain, I was putting weight on, doctor, and then my diet wasn't great. And before you know it, you're going all over the place. Flipping back is a tool that you can do quite a lot. So when you get a bit of a break, you know that one thing in that conversation has stood out that you need to focus on. Flip it back. Now, Mrs. X, you told me a lot there, but you mentioned at the beginning your knee pain. Can we go back to that again and go through in a little bit more detail? Let's try and break it down a bit and ask a few things about your knee. So you let them almost go a little bit like this, and then you flip it back to something that they've mentioned. So they may go off somewhere else, but you always flip it back, and that constant flipping back allows you to keep it under control rather than it just going out of control where you're trying to think, well, what do I talk about? There's too much to talk about, and it gets to that kind of phase where you start talking too much. So even having done that, even having tried to slow things down, even having tried to acknowledge, even tried to having flip back things to get control, you can still only manage what you can manage. And out of all of that stuff, if someone's talking for so much, they may have brought out lots of issues that you in reality have no time to cover. But this is where setting up your management is very important. This is where issues on the table is very important. Like Mrs. X, gosh, thank you so much for that information. There's a lot of stuff that you gave me there, but from talking to you and examining you or whatever it might be, there are 3 or 4 things that stand out that I think we need to try and cover. There's this. Now, look, we may not get through all that today, but let's make a start. Let's try and get through as much as we can, and then maybe we need to get you back and try and take things further to try and finish things off. But out of all of those things, which one of those stood out to you first? So a clear demonstration of understanding of multiple issues. Notice how I got a follow-up in place, like we talked about in the standard case at the beginning. Get that follow-up in early and show that, I'm not going to rush everything today, just try and get it done. I've got you in mind, and I'm going to see you back later until we get this done. And then focus on, look, where do you want to go first? Either you take that lead or they take that lead, depending on whether it's a clinically important issue or whether it's something that you can send it back to them. But then you focus on 1 or 2 things before that end of that consultation, rather than trying to cover everything that you understood. Psychosocial, like we mentioned early on, there could be lots of impacts of menopausal symptoms, and maybe that's the reason that's triggered somebody to come and see you. So what in general is the impact of symptoms on their quality of life? What's their occupational history, environment, hobbies, activities of daily living, and how are they being impacted by the symptoms that they're describing? What about the relationship, if they're in one right at present, sexual history, talking about things like libido, for example, self-image, have they been changed or impacted by the symptoms or thinking about menopause? Discussion regarding ongoing contraception. We'll talk about this going forward. A lot of people presume that because we've gone through the menopause, we don't need contraception. What's the advice around that? We'll cover that in a second. Triggers that obviously may be leading to symptoms or symptoms getting worse. So smoking, alcohol, caffeine, spicy food. Mrs. X, a lot of times people notice that certain triggers can make the symptoms get worse, and you explain the reason behind these questions, show that relevance, and any stress, depression, or anxiety symptoms. Like we mentioned, menopause can have impacts on these things anyway, but also in general, people may be getting depressed or stressed because of the symptoms that they're having to deal with, or problems in their relationship and things like that can trigger reasons for them coming in the first place. Very important to understand their mind, particularly in a menopause scenario, because you're going to be talking about lots of things potentially in the second half. So understanding those issues that mean something to that person right now will be important to try and frame that second half discussion. So what's their understanding of the menopause? Maybe they've heard this term, they think a little bit about it, a bit of reading, but what do they understand? They may have read everything out there and know quite a bit, they may know nothing at all. So understanding that is important to know where you come and start your discussion in the second half. What about treatment? If they've talked about HRT already and they're wanting HRT, what do they know about HRT? What are their understanding about it? Understanding of risks, understanding of complications, understanding of contraindications, etc. Any concerns in particular that they have? For example, the impact of these symptoms on their relationship. For example, maybe their libido is reduced and this causing problems between the couple. Fertility, maybe they're worried that they're going through the menopause. What if they still want another child? Maybe that's their concern, for example. And what about quality of life? Is that being impacted to such a point that they're having worries that it's going to get worse and worse? And why are they here really? Do they want confirmation that this is the menopause? Do they want treatment for the symptoms? Do they want HRT? Do they want referral? Do they want relationship counseling? Do they want help with their depression? Finding out what they want is very important to tailor that management plan according to them in the second half. Now, when it comes to management, you may not have a diagnosis at this point. So how do you initially manage it? Manage any urgency first and foremost. So is there anything in the story or the examination to suggest suspected malignancy that needs urgent management? Manage any conditions that they may or may not obviously have or have a diagnosis for. So eczema, psoriasis, what treatments can you use for that? Manage the symptoms. So emollients, for example, antihistamines. Again, it depends on what they've tried and what you think the underlying cause may be. And then manage lifestyle. So talk about keeping nails short, for example. Talk about looser clothing. Talk about good temperature control. And again, manage any of their worries that they may have, or manage any of their psychosocial impacts, for example, that this itching may be leading to. So again, your management is very broad-based, but splitting it into issues, both clinical and non-clinical, can help map out how you're going to manage the next 2 or 3 minutes. And maybe there's more than one factor that are adding together to make them not take their medication, alongside things like practical things that you may pick up as well. So poor compliance is not just about, oh, this is a case about someone not taking their medications. It must be about side effects, and therefore let's talk about that, because there's so many things that it potentially could be down to, and therefore your bubbles, as always, are important to pick up those individual issues that you then bring back when it comes to managing. So let's think about managing in general for poor compliance then. So again, as with all scenarios, think about the issues. Poor compliance is likely just one of at least 2 or 3 issues. So putting them all out there at the beginning might be useful. So for example, Mr. X, I'm really glad that you've come to see us today. There's actually a couple of things that I'd like to focus on. Firstly, looking at your recent blood tests and recent numbers, your diabetes control, unfortunately, is going the wrong way. Your HbA1c is getting higher. So we need to talk about the kind of things that we need to do to try and reduce that, because of the risks associated with that, which we can go through in detail. Secondly, of course, are the medications. Now, there seem to be a number of reasons why the medications are not being taken as prescribed, which is probably leading to one of the factors of your control being poor. So we can talk about medications and try and see how we can improve on that. And thirdly, maybe we can look at some more general changes from a lifestyle point of view that can also help when it comes to diabetes. And I'd like to run through a couple of those as well, because I think a few changes might make a difference to your overall management. Now, there's a few things there. We may not go through all today. I think let's start with the compliance. Let's start with the medication and maybe take things further, because that might improve your overall HbA1c in the future. And then you go off into that kind of area and you start opening it up and looking at why their compliance is poor, etc. But you see how I've not just thought this is a compliance scenario, let's just talk about compliance for the whole of management and try and talk about as much as possible. I'm getting my base in, I'm outlining the issues, I'm showing there's more to this scenario than just the compliance part. But then when you go into details about compliance, then of course you'll be looking at things like discussing pros versus cons, the benefits of taking the medication versus the risks of not taking the medication. And similarly to the health promotion scenario, you may be looking at going down a carrot approach where you overemphasize the benefits of taking the medication versus the stick approach where you overemphasize the risks of not taking the medication. So you need to have your clear reasons for why they should take it based on their own health beliefs. Again, you may need to bring in the ultimate risk of someone who's refusing to take their blood pressure tablets, talking about the ultimate risk of having very high blood pressure and the things that can happen. Again, that can sometimes be important for them to be able to make a competent, valid decision to not take them if that's what they want to do ultimately. Ultimately, they may be competent. So if you've gone to the ultimate risk point, if you've assessed them as being competent to make that decision, then you need to respect that. But it doesn't mean that because they're now not taking the medication, they're competent, we can leave it at that. This is where you look at negotiation and reasonable alternatives. Maybe you can trial it a slightly lower dose. Maybe you can trial a different medication that works similarly. And you just have that negotiation discussion to try and come up with a plan that you're kind of happy with, they're kind of happy with, that may not be exactly where either of you want, but then you can review, maybe try for 3 months, come back, recheck bloods, recheck blood pressure, for example. That negotiation sometimes is very important in a compliance case, because someone comes in with an idea they don't want the tablets for whatever reason that may be. You think they need to have the tablets or should have the tablets, and it's about being flexible and having that middle ground. But one of the first things you do before you start negotiating is talking about the ultimate risk, because sometimes if you explain the ultimate risk, then they realize they're important, and therefore there's no need for negotiation because they just start taking them anyway. But like we said, your management depends hugely on the issues that you've picked up in the first half. So you can't just skip psychosocial and ICE and think this is a compliance case, let's talk about all the things about compliance that I need to talk about, because you're not going to have that connection in the second half, because you're just saying things that you think are right, but they may not be listening because they're totally different to the issues that they have in their mind. So really important to get that balance right, so you end up with a holistic, patient-centered approach. Let's move on to chest infection then. Again, a very common presentation. You may see somebody with a cough and they may think they have a chest infection, or ultimately you may think they have a chest infection. What are the kind of things to focus on in a scenario like this? Doctor, I've had this chest infection for a while now and I think I need some antibiotics. Very common initial opening line. But again, it depends on you going through a focus history to understand the issues yourself before you have that discussion. So going through things like upper respiratory tract infection features, going through sore throat, ear pain, fever, for example, going through a focused cough history, like we talked about in the previous case, the symptom onset, the duration, the frequency, anything makes it better, anything makes it worse, for example, any sputum, if sputum is coming up, what are the characteristics of that sputum, what's the color, the consistency, any blood, for example, any associated chest symptoms apart from the cough, which may be the likely thing that they've come in the first place, shortness of breath, dyspnea, wheeze, for example, chest pain, again, things that may change your plan going forward. Any underlying conditions, yes, they may have a chest infection, but if they've got a background of COPD, then how you manage that may be different to somebody without COPD. Is it causing their general respiratory conditions to be worse? For example, bronchiectasis, if they're getting recurrent chest infection with bronchiectasis, how would that impact your management? Does it mean you need respiratory input? May they need prophylactic antibiotics, for example? Again, going through the underlying conditions as well as the current presentation is always going to be important. Obviously, some questions are going to change the way that you manage this particular chest infection. Are they systemically unwell with a pyrexia, vomiting, acute shortness of breath, chest pain, for example, may need admission? You may pick that up pretty quickly in data gathering. Is there anything to suggest suspected malignancy? So somebody who has recurrent chest infections, is there something underlying it as to why that may be the case? Looking at things like, are they a background smoker, hemoptysis, hoarse voice, weight loss, dysphagia, those kind of symptoms that may indicate a malignancy. And again, is there a worsening of an underlying chronic respiratory disease? Like we mentioned, a lot of chest infections present not because of the infection, but because the underlying condition is made worse because of that infection being in place. So making sure that you're looking at, do I need to manage this part of it as well as managing the infection side of it? Obviously, if you are suspecting cancer or if you're suspecting some kind of urgent referral is needed, there are going to be lots of red flag questions. So going back to what we said at the beginning, you've got to signpost it very well, reason it very well. The first R when it comes to interpersonal mistakes, when it comes to indigestion, there are a couple of yes/no medical questions that we'd like to go through. We're just going to run through a few if that's okay. Don't assume that red flags have already been asked in the past by somebody else. Don't assume that red flags remain the same. For example, like we talked about earlier, if someone has a chronic history of something, don't just assume that things haven't changed. Ask about between last time and now, when we last saw you and now, just going to see if things have changed, if that's okay, and go through those red flags, because it's amazing how quickly they change. And that might be the trigger that actually got them to see you today that tells you that this is an urgent referral for this particular presentation. Understand support systems as well. Very important. Again, if you're going to be telling somebody that they need to see a specialist urgently because you're worried about XYZ, you're going to need to think about who's at home with them when they go back from the clinic today to their home, who's going to be there when they start worrying about this at midnight, for example. Understanding support systems and data gathering, very important. Expand on potential blockers. We briefly talked about blockers in the admission cases. Same principle for urgent referrals. If someone mentions they're going away in 10 days, if someone mentions a wedding is coming up next week, if someone mentions that they've got an important interview coming up in 2 days' time, and you know that you're going to be talking about an urgent referral that's going to happen within the next 2 weeks, then you've got to be expanding on these blockers in the first half, finding out a bit more about the situation so that when they come up in the second half, you've got a bit of ammunition to talk about and you've already thought about a few ideas that you can use later on. So again, potential blockers. ICE, Very important when it comes to an urgent referral case. If you are thinking of a suspected cancer scenario, there's a big difference in how you manage that second half based on have they actually thought about cancer themselves? Has it crossed their mind? Or are they completely oblivious to the cancer thought at all? It's just not gone through their mind at all. Big difference how you manage that. And was there anything in particular that you thought that we might do? Because even though we're thinking, okay, this is a potential cancer or this is a potential urgent chest pain referral case, we're going through all of our mind about what we think needs to happen. But really important to bear in mind what they thought. Maybe they already wanted a referral, so it's easy. Maybe they didn't want a referral and they just wanted a letter to say everything is fine. Maybe they wanted some kind of investigation. But remember, just like in all cases really, but particularly in these cases, ICE is super important to set up how you manage their mind in the second half. So again, the 3 bubbles help here. You've got your red flags, which are very important. You've got your psychosocial, which is where your support systems and blockers will be opened up. And of course, ICE. So again, just like any scenario, those 3 bubbles are going to make or break how much information you have ready for the management plan. Now, when you get to a management plan in an urgent referral, lots of psychosocial links when it comes to acne, Mr. X. When it comes to acne, there are lots of things in our lifestyle that may be impacted or may cause problems. So can I go through a couple of things about you and your life, if that's okay? Remember, every time you are psychosocial, link it with that person's presentation to show that I'm choosing these questions for you rather than going through a set list of psychosocial questions that I have to do for everybody. Like with any skin condition, we mentioned this a few times, and I never underestimate mood, anxiety, confidence. Subjectively or objectively, it may look like the acne is actually not so bad, but it's one of those subjective conditions where the patient may not think, even though objectively it looks okay, the patient may be very impacted by it, or you may get a patient who has what seems to be objectively very severe acne, but they're completely fine with it from a mind point of view. So again, asking these questions is important rather than assuming the answers. Any underlying health beliefs. Sometimes people come up with lots of these things. I'm eating too much of this, or I'm not eating enough of this, so I've changed my whole diet completely. That may be health beliefs that you need to be talking about, but going through diet may be important. Cleanliness, what's their regime? What are they doing from a day-to-day basis? Again, there may be things there that you may need to be discussing later on that may actually be causing harm. So important to pick these things up in psychosocial. Occupational history, could there be anything in their work environment that may be leading to increased acne or risk of acne? So chemicals, talk about the temperature environment they're working in, for example. And also, of course, what's the impact of acne on work? Maybe somebody's missing multiple days of work because their confidence is so low because of acne, and maybe they're about to lose their job, and that's why they've come in to see you. So important to ask these kind of questions. Relationships, of course, are they in a relationship? Is anybody supporting them through all of this? Who do they talk to about this? But also impact. Is the acne causing a problem in the relationship, or is it causing strain, for example? Or are they worried that it may cause a problem? So again, talking about this is important. And also, if you get a female with acne, talking about relationships. Are they currently in a relationship? Are they trying to become pregnant as a couple, for example? Are they taking contraception? Again, important to ask about because they may impact how you manage that particular case going forward. We'll cover these in a bit more detail as we go forward. But do talk about, if it's a female, plans for pregnancy. Are they using contraception? Do they need contraception? Again, they can help you weigh up one treatment plan versus another. Like with most presentations, there are certain questions that you cannot afford to miss, things that will change how you manage things from an urgency point of view. So asking clearly about suicidal thoughts or ideation, particularly about any plans in place or any arrangements that they've made, any history or thoughts of deliberate self-harm. Is the depression characterized as severe based on the symptoms that you're talking about and the impact that it's having on that person's life? And anything to suggest suspected psychosis, delusions, hallucinations, mania. We'll cover these in more detail. Sometimes asking these kind of questions can be quite challenging, so asking it in an open way and a clear way with a bit of a signpost would be really useful. Sometimes, Mr. X, when people feel down or low like you're describing, they can feel at times that life is not worth living. Have you had any thoughts around that, or ending your life? Again, putting it into the third person sometimes helps. Mr. X, sometimes when people feel low, they can have thoughts that life isn't worth living, rather than have you had thoughts where you want to end your life. Again, taking that you out of it sometimes can make those questions a little bit easier to ask, but you do need to get through them in order to rule those significant things out. Obviously, there may be a lot of links with psychosocial life and mood, either low mood impacting their life or things in their life going on that are causing them to have low mood. So make sure you spend a bit of time when you go into the psychosocial bubble, Mr. X, when sometimes when people feel low, they can turn to things that they think may help, things like smoking, things like alcohol, even drugs sometimes. Can I check if you've ever been tempted to use any of these to try and help? So again, rather than just saying, do you smoke, do you drink, do you take any drugs, bringing it into a way where you can talk about them as a possible use against the low mood may be a nice way to bring it in to a consultation like this. Talk about exercise, dietary and lifestyle factors. Again, they can be influenced by low mood. So perhaps someone was a keen sports person and now they're just not doing it anymore. They really don't feel like it. Or they may have COPD and their exercise levels are dropping because of the condition, and that's leading to depression. Again, looking at those two things are important. We talked a bit about impact of how you eat and your appetite and diet when it comes to low mood. So are they now depressed so they're not eating healthily, whereas they always used to do that? Or, for example, is it because they're so depressed they're not leaving the house and therefore they're not able to buy good food? Again, these kind of things may all be linked. Quality of relationships, so what's their support system? If they have anybody around them, do they talk to them? What do they think about their low mood, for example? Do they have a support network? And knowing that, it's important to know, how do I manage the support side of things in the second half? If they're in a relationship, any sexual dysfunction that may have occurred alongside low mood, and generally what's the impact of the low mood on their quality of life and activities of daily living. Also talk about things like living conditions, occupation. Again, they may have lost their job and that's caused depression, or their low mood is leading to work issues, both very important to pick up. And also living conditions. Has their house been neglected, for example, because they're feeling so low? And is there any inputs that can or are needed or necessary from that point of view? Any current stresses that may be linked with possible causes, so relationship stresses or issues, bereavement recently, any health issues like we talked about, any problems at work like we talked about, problems at home like we talked about, education issues, particularly in a younger person, are they struggling with exams, for example, and any financial issues as well, and any relevant community or cultural factors. So, for example, are they living in an environment where there's a lot of stigma around mood disorders and therefore maybe they've never spoken to anyone about it, or feel that they can't get any support from their usual people that are around them. So again, these kind of things can make a big impact on how you make your management more tailored to that situation, rather than just managing depression as from a guideline point of view. And a few final points on some of those questions that we talked about in terms of expectations. Doctor, I know it's a viral infection, but can I have antibiotics? So making sure you have practiced and gone through a way of explaining viral versus bacterial in a simple, focused way. Sometimes I see people spending 3-4 minutes trying to explain this and still kind of coming out with a very confused picture on the other side. Discuss about resistance, why antibiotics are not necessary to have on a regular basis. A, because it doesn't help in viral infections, but B, because resistance can build up and then when you need that treatment later on, it may not work as well. So discussing all of that can be useful if someone keeps pushing for antibiotics in a situation where you don't think that they need to have it. Doctor, should I have cough or cold remedies? I've seen lots of things on TV, lots of adverts in the pharmacy about buying these things. Should I have them? Remember, explaining that these kind of things are not going to impact the virus itself. The virus is going to do what it has to do and hopefully the body will fight it off itself, but it may help with certain symptoms that they may be struggling with at that particular point. But remember that some of them may cause side effects, for example, drowsiness. So important to go through pros and cons and talk about the fact that there's not a lot of evidence behind these things, although some people do find they help with certain symptoms. So again, these are the kind of things that when it comes to this kind of presentation can allow you to build those scores to something a little bit higher than just what we'd expect when we see a simple viral upper respiratory tract infection. The guidance depends on whether it's an adult or a child. Now, most people who present are going to be adults, so you'd be advising an optometry assessment, so visiting an optician for a full eye assessment of visual acuity, for example, and all the other bits that they do. But there are certain indications, of course, ultimately, that you would look at surgery to try and help with cataracts. So when the visual acuity is affecting somebody's life, when they're getting comorbidities, for example, falls, and increased risk from that point of view, or if there are other eye conditions that may benefit from the cataract being treated. So again, there are lots of indications for referring for an opinion for surgical intervention when it comes to cataracts. And in general, just remember, if it's affecting their life, then it's reached that point already. But if you get a presentation or a consultation of a child or a baby who presents with a cataract, remember that needs to be an urgent ophthalmology referral to rule out things at the back of the eye that need pretty quick intervention and treatment. And finally, when it comes to gradual vision loss, a few words about diabetic retinopathy. Of course, you can have hypertensive retinopathy as well. Now, when it comes to management initially of a new antenatal presentation, you're thinking about which route do I need to take? Is it an admission, i.e. I'm worried about an ectopic pregnancy, someone's very unwell, I need to get them into hospital right now? Am I referring for consultant-led care or shared care, where it's consultant plus midwife, and there are indications where you may think about this, which we'll talk about in a second? Or are you thinking about kind of more routine midwife-led care, where there's not really any indications to get consultants or proper obstetric teams involved? So how do you make these kind of decisions? So it depends on things like current symptoms and examination. Obviously, if there are things in the history or the examination that indicate admission, then you need to be acting on those things. It bases on medical history. Someone may have a history of brittle asthma, for example, a history of epilepsy. They may have a history of cardiac disease. Again, these are more likely to be consultant-based referrals. Drug history, are they taking things like warfarin, insulin, methotrexate, things that will need some kind of consultant input in terms of monitoring their pregnancy going forward? It could be based on the obstetric history, so GXPX, how many times they've been pregnant, how many children have they had? And of those children, were there any complications, for example? Were there any issues that indicate that, okay, this pregnancy needs a higher level of care, for example, a high level of input, for example, a consultant-based care? Any background of stillbirths, background of miscarriages, background of termination of pregnancies, background of ectopics, all these would influence your decision as to whether it's kind of routine run-of-the-mill midwife referral or whether it's a consultant-based referral initially. Background of cesarean section, background of preeclampsia, things like previous stillbirths, like we mentioned. Again, all of these need to be taken into account to make that decision. Is it today admission, consultant-based referral, routine midwife-based referral? Doctor, I've heard a bit about folic acid. What's this all about? Why do I need to take this tablet? So again, it's important to know the guidelines, the NICE CKS guidelines in terms of folic acid. You take folic acid, remember, to reduce the risk of neural tube defects developing. The ICE, of course, an important bubble when it comes to MI. Lots of things to cover from a mind point of view. Really important to fill any gaps in understanding. If someone has had a recent MI, they've probably been through lots and lots of things in a very short period of time, probably spoken to lots of people about lots of new things. Really important at this point in data gathering to understand where their mind is, what their basic level of understanding is. So again, you can take over later on and fill in any gaps. Important to handle any concerns they may have. They may be concerned about dying now they've had a heart attack. What happens, doctor, if I have another heart attack? I'm really scared. Doctor, I work on, I don't know, high-rise flats, for example, at the top of big buildings. Is there any impact on my job? Again, there could be concerns that you may not know about until you ask, or if you don't ask, they might come out near the end. So really important to get them all out in ICE. And then important to see if there's anything in particular at this stage that they were looking for. Of course, you've got lots of things in your mind that you know you want to talk about in management, but what actually do they want at this particular point? Do they just want a re-explanation of what happened? Do they want a discussion about medications and why they're on all these medications all of a sudden? Do they want to talk about things like driving because someone told them that they may have an issue with driving now at this point, or someone mentioned it in hospital and they want to clarify that? Again, unless you ask what's going on in here, your management plan is going to be very limited in terms of what you can do. And let's focus on insomnia. Doctor, I can't sleep. I'm really struggling. Is it true that I have insomnia? Now, when someone comes in with problems sleeping, remember, there are lots of reasons that they may think their sleep is affected. And it's important for us to understand, what do they mean by that term? So is it a challenge to get to sleep in the first place? Are they just struggling to drop off? Is it a challenge to stay asleep? So they may go to sleep really easily, but they wake up multiple times throughout the night. Is it that they're waking up very early in the morning? It could be a kind of depression picture, but they're talking about it being a sleep issue. Is it that they actually sleep okay, but they wake up not feeling refreshed? So they feel like they haven't slept, and therefore the rest of the day is impacted. What actually do they mean by the term sleep problems or insomnia? Worth understanding fairly early on. Remember, there are two main types of insomnia. You have your primary insomnia, where there's no underlying cause. Probably the majority of people have primary insomnia. And then you have secondary insomnia, when it's associated with something else. And we'll talk about some of these things later on in the case. And remember, insomnia is termed long-term if someone presents with over 4 weeks of sleeping problems. And there may be different things you can do in management when it gets to this particular stage, in case it presents to you in a consultation. But at some point, going through a focus history is going to be important. Duration of symptoms. How often is it an issue? Is it getting worse? Is it getting better? Has it been stable for a number of years, for example? Tell me about your normal sleep patterns. So getting a bit of an idea about what's normal for them, perhaps what was normal before and what's normal now, and to see how things have changed. So what's their normal sleep-wake routine like? So how long are they asleep? How long are they awake? Does that change? Are they napping throughout the day? Is that because they're so tired they need a nap, or it's just habit that they have a nap? What's the possible links there? Is it difficult, like we mentioned, is it difficult to get to sleep, or are they waking up in the middle of the night, or are they getting early morning awakening? Are there physical symptoms that are stopping them from sleeping? So are they having to wake up at night and pee more often, for example, or urinate more often? Again, have they got nocturia, frequency, urgency? Are there respiratory or ENT symptoms that are stopping them from sleeping? Dyspnea, for example, PND. Are they snoring with OSA, obstructive sleep apnea? Are they having these apneic episodes? Are they getting tinnitus that's stopping them sleeping? So again, symptoms that stop people sleeping. Any GI symptoms that may be occurring at night, reflux getting worse, nocturnal dyspepsia. Is there associated tiredness because of the fact that they're not sleeping very well? Are there things like chronic pain syndrome? Maybe sometimes people are just having such severe pain that they can't sleep at night. Maybe that's the underlying issue. Are they getting things like restless leg syndrome that's stopping them from sleeping? Again, there are lots of physical things to bear in mind. Could it be a first presentation of menopause, for example? Someone describing feeling very hot at night, sweating at night, having these classic hot flushes, and that's what's keeping them awake. Any recent changes in environment, new mattress, newborn baby, anything that you can think that may be influencing their sleep worth going through in the story. Any associated memory impairment, delirium, acute confusion. Hopefully this would be apparent fairly early on. Going through a drug history, looking at things that they may be currently taking, like steroids, but also what are they taking in the past? Those classic Z drugs for insomnia, zopiclone, zolpidem, those kind of things. Any relevant previous medical history, things that, for example, may be not under control from a physical point of view that are then waking them up at night, so poorly controlled COPD, heart failure, for example, and any relevant family history, for example, things like depression. So lots to think about in a focused history point of view, but bear in mind physical symptoms that can keep them up at night, or a primary insomnia picture where there's nothing physically that you could understand as to why they're having trouble sleeping. A couple of red flags to bear in mind. Is there a background of agitation or psychosis? Is there a background of severe depression, which is kind of masquerading as insomnia? And with that, could there be ideas or thoughts of increased suicidal risk or things like deliberate self-harm? Again, these hopefully would all stand out in the story and indicate the need to do something perhaps a little bit more urgently.